It is just a huge, huge honor for me today to be podcasting the GOAT oral surgeon of Arizona in our backyard, Mr. Paul Kelly. And he has. I mean, he's even done all my work, all my implants, and he is a legend. My gosh, I could read his bio. Let me just read the formal deal. Today, we're joined by someone who's been a trusted name in the East Valley of Phoenix, Arizona for almost 2 decades. Dr. Paul Kelly, dentists, physicians, and patients all know him not just for his skill, but for the genuine care he puts into every interaction. Year after year, his peers have voted him a Phoenix Magazine top oral surgeon. Dr. Kelly is a board-certified oral maxillofacial surgeon who handles everything from wisdom teeth and dental implants to treating facial pain injuries. His journey took him from the University of Utah to the University of Louisville. I think that's where Gordon Christian went, right?
I don't.
Yeah,
did he? Yeah.
I thought he did his pros residency there.
Right.
And then to a residency in Wisconsin. It's a cheesehead, which is weird because I saw him eating spray cheese out of a can, Cheese Whiz. So
that's right.
I don't think they do that in Wisconsin. But beyond the surgical precision, he's a proud father of 4, a Gilbert local, and someone who truly connects with his patients on a personal level. A big shout out, thank you to all the missionary work that you've done. I mean, you're just an all-around class act guy. So let me start with the first question. Take us to the beginning. What made you choose oral maxillofacial surgery? Remember, we got probably at least a third, maybe 40% of our audience. They're in dental school right now, and they're thinking, should I be an oral surgeon? What was the training journey like from dental school through residency? And then when you got out, why Gilbert, Arizona? What drew you back here?
Yeah.
And answer it to me like you were talking to a dental student who's
that's
in dental
perfect
school.
because lately this summer I've had multiple dental students through shadowing, doing sterile, working for me, and I think with my alma mater, Louisville, I think I've placed maybe 4 dental students that are either freshmen or sophomores there now. So I feel like I can connect with that group, and that. Maybe it's just me trying to hold on to my youth, but in a lot of ways I try to think of myself still in that stage, right? I'm still hungry. I still want to work hard. I still put in long hours. My father's a pediatrician. He practiced till he was 70, and just a excellent, great man, steady as can be. And I thought maybe I wanted to do med school, right? Do pediatrics, something along that line. And so when I was in school, sometimes I'd go study at his office over the weekend, get my biology, chemistry going at his office and focus. And I thought, is this where I want to be? And I shadowed him. I shadowed other physicians, ophthalmologists, orthopedic surgeons. I went through some different offices and went back to my Boy Scout master. Great guy named Ralph Reiser, if anyone knows Ralph Reiser, LSU grad that practiced for a number of years in Salt Lake. So I went and I shadowed Ralph Reiser, and I'm like, wait a second, he's playing dentist and physician. That's kind of in my head what I saw, because my dad didn't do much with his hands, right? Like he thought it was a big deal. Like, hey, Paul, let's go. We're going into the hospital. I'm going to do a circumcision, and it was this little bulb and a little string. It wasn't really surgery. Sorry, Dad, but it really wasn't. And so I really liked shadowing an oral surgeon, and so I pivoted. I started going that route. We applied to a bunch of schools, got into a number of places, chose Louisville primarily because I liked the feel and the vibe of the school, and I knew a couple of guys out there. We loved our experience there. So I went into dental school thinking I was going to do oral surgery, which is a bit of a risk. I learned to love the dentistry part too, but when it came to what procedures I wanted, I thought it was more on the surgical side. I had one brief little pause. Not a lot of people know about this one, Howard, but when I was in the application process between your 3rd and your 4th year that summer, I thought, man, a lot of I'm hearing the residency is hard. It's it's longer. It's hard on your marriage. At that time I'm still married. We have 4 kids now. At the time we had 2, and I thought, can I do this? I kind of questioned myself a bit, and I thought, well, maybe I should do orthodontics, right? So I don't know anybody that did this, but I applied to both orthodontics and oral surgery at the same time. One was on the first match that came out, I think, in January. The other match came out a month later. And so I went and applied, interviewed at a bunch of orthodontic programs. And orthodontics, they played a little different than the oral surgeons at the time, back in, what would this have been, 2002-ish. They contacted me. I got contacted by 2 programs in the orthodontic residency world, and they said, hey, mathematically, if you rank us, you're in. But they were in the first match. So if my match number, you only get 1 match number. So when you submit the match, you can't take it back, right? In other words, so if you submit and you match at NYU in New York, but you decide, I don't know if I really want to go. Instead, I want to do oral surgery, and I want to go to Indiana or Iowa or Wisconsin or Texas or wherever, it doesn't allow for that pivot. So right up at the last moment, so I had... so you can submit and then you can withdraw from the match, but you have to withdraw. And this was back in the dial-up computer internet days. You remember that, Howard? So I'm like, I think maybe I should do orthodontics. It's easier, even though I was like, I don't know if I really want to do it. But I thought I had enough interest. I like the facial kind of, facial generated treatment planning, that kind of stuff I liked. But I really liked throwing sutures, mallet, chisel, drill, that kind of stuff I liked. So I submitted the match in the morning on I think it was a Saturday. My wife and I went to dinner with some friends in dental school. This is now the beginning of my senior year. The OG original, I think, Harry Potter movie was coming out that night. We were all going. And my friend turns to me and says, man, you do not look good. And I said, man, I don't know what I'm doing. Like, I'm submitted this match, and he says, you need to get out of here and go figure this out. You only got till midnight. So my wife and I left. She's my wife, Kara. She's awesome. She's still my rock that way. I literally was like on the couch, on the floor, saying, I don't know what to do. And she said, I think you want to do oral surgery. I think you think it's too hard for you. I believe in you. I think you can do it. And so we withdrew from the match, from that part 1, and the rest is history. So I love it. I love what I do. I still have a passion for it. I still work long hours. This week is funny. So what are we? We're recording this on a Friday. I worked this morning. Everyone in my office, and you met some of those great people that work for me, Howard. They were all giving me some business this week. So I probably shouldn't tell this story, but maybe I will anyways. So I had a colonoscopy, just standard screening colonoscopy on Wednesday. It was at 1:30, right? I worked that morning. I had patients scheduled till noon, right? And so now I don't know a lot of people do that, like have a colonoscopy on the same day they're working. But I just, there's a certain number of patients I'm trying to see, a certain number of referring doctors I'm trying to keep happy, make sure that their needs are met, and it's a little bit tricky at times as an oral surgeon to say, look, hey, I'm playing the hat of the doctor that's trying to keep a patient flow steady going through the day and then work in emergencies coming from other offices. And so it's a balance, and I've enjoyed it over the years.
Do you remember the oral surgeon here that we lost from colon cancer? He was from Wichita, Kansas.
I heard of him. I don't know if I met him. But I'm trying not to be that guy that has any
I'm from Wichita,
death,
Kansas,
so I'm trying to screen everything.
Every Thanksgiving and Christmas, we both had 4 kids.
Yeah.
So we both had an entire 3-seat row of the whole family flying back and forth to Wichita. And my gosh, and he, they were the screenings. They'd say, you get your first one at 50. Mm-hmm. He got diagnosed with that. He had bleeding going in there. He's 49. And he's just like an oral surgeon, and he's just like, God, I mean, I was going to do it when I was 50. If they would have told me, now that he was looking at all the literature, and he said him looking at the literature, he would have told himself, no, it needs to be done at 45, and he'd still be alive.
Yeah, and they switched it. I don't know if you know that. They switched it to 45. So I had my first one at 45, and I have my list of kind of just things. I tend to be more proactive, try to stay healthy, try to do yoga. You can't do oral surgery, in my opinion. It's hard to be an effective, good private practice oral surgeon and have any major health issues. If you have neck, back,
because colon cancer is an almost non-event if you get your screenings.
That's right. And
it's
one of the few ones out there, right? That if you screen early enough,
That was such a brutal
Yeah.
death. But it takes us back to a whole different question about single versus group.
Mm-hmm.
So you're a single guy, so you have just a colonoscopy, and you got to get right back in there. Does it? So do you ever start thinking, if you were part of like and there's some DSOs that are coming out in oral surgery, but
Yeah.
do you ever think if you were in a group or a larger
Right.
setting,
Well,
you could?
well, Howard, you
What are
bring
the
up a good
pros and
point.
cons
So
of that?
my background is, so I came to, this is my, I think, my 19th year in the East Valley. I came here in 2006, I believe, and I was with a group practice that had 3 other doctors, and I was an associate for 1 year. After 1 year, and 25% owner on paper by, just how we split things up, right? I was, as great as guys as those were, and this is nothing but nice things to say about my former practice. I wasn't a 25% say, right? I was a blue personality and a sea of red personalities, if that makes sense. So I didn't get the opportunity to hear my voice heard much in the practice, things I wanted, right? So when my partners and I came to an agreement that we were going to separate, I decided, and that was 10 years ago, so I've been 10 years on my own. I said, look, I can do this, and I can make it more personal to my patients. I can make it a better experience, and I get to control everything. And that was huge. That's been the biggest pivot of my, not just my career, but my life. In other words, it was, at that time, being in a group practice was stressful for me, right? I throw 20 procedures at me a day back then, and I could get through that just fine. Throw me in a board meeting with my partners, right? 6 o'clock in the morning with just my partners talking about stuff. That was stressful.
Oh yeah.
And so to me, having that freedom for the last decades made a big deal. Now I know I'll need a pivot. I'll need to bring somebody on and this kind of stuff. So those are natural pivots. The DSO thing is an interesting play. I've had a lot of friends in town do, whether they're general dentists or other specialists, go that route. Oral surgery, I think, is one of those. I don't want to say the last untamed DSO kind of market, but they're going heavy after it because I think they can. If you can buy the doctor's practice, you have the asset. If you have the asset, you control them. If you control them, you control their schedule. You control the P&L. You control a lot, and so it's not like there's not some benefits to those kinds of things. I'm not hating on any particular way. Practice however you want. Practice however you feel. But for me personally, freedom, wealth, career satisfaction, personal fulfillment, those things came when I was a sole owner. And then I'll give up some ownership at some point. I'll bring somebody on and have them feel some of the same things. One day, like Howard, I think you probably could resonate with this. Once I had my new practice opened, a few weeks in, seeing patients, things were going good. Go to arm the alarm, flip the lights on, and I, see some wrappers, a few things on the floor, right? I walked over, I picked it up, and it was the weirdest feeling. It was all of a sudden like, wait a second, this is me, man. I'm picking this up because I want this place to look good, right? I pick it up because I want. This is the projection I'm having I want it to have out to my patients, that we're clean, we do good work, we're friendly, we're trying to make oral surgery a personal experience, help you have. A lot of people are fearful for coming to see an oral surgeon. I'm trying to change that, and so that was a big difference. Even though I was an owner in a group practice, as a minority owner, or if that makes sense, I just felt like it was a little bit different. So.
Yeah, and those those DSOs is the founding father an oral and maxillofacial surgeon board certified that you'd let work on you?
If the founding father of a DSO was an oral surgeon, would I let him work on me?
No, I'm saying, are these DSOs in oral surgery? Are they owned and operated and ran by a board certified oral and maxillofacial surgeon that you'd let work on you?
No, I mean,
Are they?
I don't think so, right?
Yeah,
So
yeah.
I wouldn't. Not that I'm aware of. I had
Not that
a
you're
group.
aware of.
I had a group
That's
pursue me once, and
that-
they flew in their kind of money man behind the things, right? So I think he was the most wealthy man I've ever met. Nice, humble guy, good guy, and he'd worked hard for his money. It was outside of dentistry. It came. He sat on my couch. He sat across from me, and he said, "I said, hey, why should I sell?" And he said, "Because I can run your practice better than you can run your practice." And I gave him kind of the courtesy head nod like this, and then that question haunted me for that weekend. I'm like, I can run your practice better than you can run your practice. And I thought, all right, he's got an MBA, he's got the credentials, he's got some stuff. I said, man, you don't know relationships. Oral surgery is a relation-based specialty. People occasionally will choose an oral surgeon based upon convenience. Hey, he's the guy next door. He's the closest to me. He can get me in because somebody's got tooth 14 that's lighting them up, but they can't sleep. So there's some of that stuff, right? But when it comes to trusting who is your go-to oral surgeon, that's different, right? That he or she is somebody that will answer that call any time of night. That's somebody that will bend over backwards. He or she has an office staff, a team, right? That their purpose is to make the referring doctors burden lightened as they make that call, transferring that patient and transferring that trust over to you. And that transfer of trust is huge. And so who knows what the future of dentistry is, right? I mean, this is largely this is why I respect you, Howard. I mean, you've ridden this ride, this train for a number of years. There's been lots of waves. There's been a lot of cool products come out. Then there's fade. Everybody's using the gentle wave and endo. Then they're not. They're using this implant system. Then they're not. There's a lot of trends and fads that happen. Business ownership may not be one of those things, right? In other words, in the end, it may end up being business owners that were owners, operators, the kind of the OG dentists. They had it right. And these waves will go like this, and it may full circle back to saying, hey, this is the best way to do things. That's my current thought. I mean, private equity money and that kind of stuff, timing of retirement, health, what your health is like, what your family goals are. I mean, there's a lot of things that get involved with that. So it's right for some people. I will say that it's right for some people for sure. Nothing's right for everybody at the moment. Right now, I'm loving what I do, and I feel like I can best do that as an owner operator myself.
My gosh, I can't even tell you how many oral surgeon stories I've heard where they came in and just comically destroyed the practice. Talk to Jay Resnick.
Yeah.
I mean, it's just like it's just delusional that people think. I mean, I keep telling people about Boeing. When I grew up in Wichita, Boeing, their second biggest plant out of Seattle was in Wichita, big old fuselage deal. And the CEO of Boeing was always an aeronautical engineer that would be like Gordon Christian or Pete Dawson or Carl Mish or someone that everybody's like, what did he say? What did he say? And then the MBA said, step aside. And they left Seattle and went to Washington, D.C., where the money is.
Yeah.
And they got a non-aeronautical engineer, and that's where all the money is. And within 3 years, their planes are falling out of their sky. I got a nephew that works at Boeing, and I just better stop it there for his own job protection. And and you look at these DSOs, and some of these kids, some of these guys working there, they say, well, I can't believe they do this and this. I said, well, I'm sure your CEO does this on his patients every day. Well, he's not a dentist. Oh, really? I mean, really? I mean, as the words came out of your mouth, did it even sound like a dentist could say something like that?
Yeah.
And you work for a DSO ran by someone who's not even a dentist. You're Boeing with planes falling out of the sky.
Right.
And
I had a guy call me one time in local business, a guy in private equity. This has been probably 6 or 7 years ago, and he said, "Hey, Paul, tell me the difference between like a 3-surface filling versus a crown, because I'm hired by this company to help run this DSO on the backside, and I think we should be pushing everybody just to crown every tooth, right? Yeah, that our profit margin's better on that, right? So they just can't understand the nuances with dentistry, and so I think for sure
it shouldn't even be legal.
Yeah,
It shouldn't even be legal. I mean, to own an an oral maxillofacial surgery DSO, and you're not a board certified oral maxillofacial surgeon. I mean, are my colleagues drunk?
Right. No.
I mean, why isn't this on the books and for a
Right.
federal law?
And Howard, another thing that's huge, right, is because our model is different than the American Medical Association, the American Dental Association, right? So I got a brother; he's a plastic surgeon, great guy. My son shadowed him the other day. He's shadowing me. You know, he's in college. He's shadowing my brother to see some of the plastics procedures, and he's like, his first thing he said is, "Dad, hey, you know, your brother, all his procedures were in the office that day were under local anesthetic. Why are the majority of yours under, general anesthetic?" And it gave me a chance just to talk a little bit about this. When it comes to governance, who governs your license, right? That's a big deal. And for oral surgeons to have the ability to sedate, now I don't know if we'll always have it, but we have it for now. And for pediatric dentists, for other licensed dentists that take some additional time to learn some of the sedation principles and emergencies and management of patients and complications, right? That is huge. It's for a managed care group, a DSO, to come in and somebody just pushing the financial number saying, hey, look, charge 45 minutes for anesthesia, keep your patients asleep longer. Whatever. I'm not accusing them of doing, but I'm assuming that there's some, some number kind of fudging probably going on at that high level. I mean, this is different, man. This is patients' lives. This is sedation. Oral surgeons, we take a lot of pride in having a good, clean reputation nationally of being well educated on emergencies, complications, and how to sedate patients. And it's a big part of dentistry. I mean, a lot of people don't want to get work done awake, right? They want to be sedated. And some of the stuff we do can totally be done awake, and some is hard to do awake, right? So I'm a huge advocate for trying to protect that right to be able to do our own sedations. And that's the American Dental Association going to bat for us. And then for oral surgeons, the American Association of Oral Maxillofacial Surgeons, I mean, it's a big battle right now, right? Because there's been position papers, other stuff come out and challenge that, saying, hey, should the one provider model be still one that's utilized in dentistry when it comes to oral surgery and in some cases pediatric dentistry? I think it should. I think you got to be well educated. I think you got to be well equipped in your office. You got to have great team members, and you can't go cheap on anything because it's somebody's life in your hands.
Okay, so again, a third of all of our viewers are in dental school, and they're hearing. And one of the biggest stresses that they're telling me is they hear exactly opposite advice.
Yeah.
And they're listening to, and I'm not making fun of TikTok. There's amazing people on TikTok. I'm on TikTok. I'm on all those things. There's great people. But there are people that sit there and say that every extraction site needs to be bone grafted. And then others say not true. There are other ones that saying that when you extract a tooth, every tooth you can extract and place implant every single time. Right. And other people are saying, no, you can't do that every single time. Sometimes you got a bone graft, let it sit 3 months. So can you clear up those two deals, those two exact questions?
Yeah, sure. Well, I mean, I guess what I would say is for dental students learning the ropes right now, you got to realize you're just barely getting introduced to some of the vocabulary. You haven't seen complications. You haven't had some of these things happen to you. So when it comes to extracting a tooth, I'm a believer every general dentist should be competent, be able to be proficient at extracting teeth. Now, what they may choose to do is say, hey, it's not beneficial to my time because my time has these other, I got the crowns, I got veneers, I got some endo, I'm doing whatever procedures they're doing. So you got to have your time where you say, this is my boundary, this is what I'm keeping, this is what I'm sending out. Here's my guy I'm going to, and here's the communication between the offices, right? So when it comes to extractions and implants, a lot of extraction sites can be immediately implanted, but just because you can do it doesn't mean you always need to, right? So if you're taking out tooth number 4, it's a single-rooted tooth, sometimes double-rooted tooth. You can sink the implant at a good depth, good angle, and not kind of handcuff your restorative dentist on where that screw hole is going to come through, right? Then go for it, right? on a tooth number 3, like a first or second molar with 3 roots, yeah, you can kind of go on that interseptal bone. You can tap the sinus up, but you might have to place it deep. You may have some guys like to go on the palatal root, and then they'll kick that screw, way more buccal. So just because you can doesn't mean it's ideal in every circumstance, right? So I try to say, well, what would I want in my mouth? And I know most good surgeons, most good general dentists will apply that same thing. What's predictable in my hands, right? What would I do in a family member's or a friend's mouth? Is it a big deal to do this in 2 steps versus 1 step, right? And I do a lot of immediate implants, right? But I do a lot of 2-phase stuff if I think it's going to change the depth or angle of my implant, and it would be better to do it in a 2-step. So that's one. Does every extraction site need to be grafted? No, probably not, right? I mean, there's sometimes there's a lot of bone, big wide ridge. Keep in mind, it's hard. It's hard to recreate bone after you've extracted the tooth. So you pop out number 14, you got a low, pneumatized sinus, and then a patient doesn't want to do grafting, or you don't offer it at that particular time, and now all of a sudden you might have 3 millimeters of native bone, right? That might may put you in a bind, saying, look, now I might need an open sinus lift versus just a closed sinus lift. Had I grafted it and maybe had 7 millimeters or so of bone, now I can bump up the sinus a few millimeters. So I do graft a lot of sockets, but does every socket need to be grafted? No. Just like some of the materials you can put in. You can put on PRP, PRF, all this kind of stuff that may jumpstart some healing. Does that have any long-term benefit? Likely not, right? There's a lot of products out there, right? And I think one thing maybe a lot of these general dentists can learn is you'll have people come by all day long selling you stuff, right? Today's Friday. I did probably, 16 cases or so this morning, and then zoomed off to meet you here. When I went to grab my keys on my desk, I had 2 sets of brochures from new reps dropping stuff off today. It was just one day, right? And it's like samples of stuff, and it's like, buy my membrane, buy my product, and so if you hop on any of these, if you hop on every one of these things, you'll be a poor, struggling dentist, right? What I would tell these general dentists to do is, whatever you find is your, it doesn't have to be a passion. I think that's too strong a word. If you find a liking or interest in some procedures, but find a way to get super proficient at it, right? And so, 2 new general dentists, came to my side of town recently, and I've met. I said, hey man, come on over anytime. When you're slow, pop on over. If you got a Friday, you want to come see some stuff, pop on over. I believe in making that connection, building that relationship and trust, so that if they have a complication, they know where I'm at. And I'm happy to play whatever role they want. I'm happy to support them in whatever role they want. And I think that's a relationship that's legitimate. It's not one based upon just a referral pattern. It's one based upon mutual respect for what they're trying to do in their practice and what I'm trying to do with my team.
Paul, I got burned on an implant case really bad one time. It broke my heart, and I've seen it put the same case on Dental Town a dozen times. That is, someone comes in, they're 60, 65, and you place 2 implants, and you do a 3-unit bridge, and it's perfect. And then you get a call, could you go visit my mom in the nursing home? She's ill, and you go in there. Now she's 80, 85 nursing home, and the back implant failed or whatever, and now you have to, section off 2 teeth and lose the implant, and you're sitting there thinking, man, if I would have placed 3 implants, I could have just pulled out that failed implant and taken off those 2 crowns and rebuilt her 3-unit bridge right there. What do you think of 2 implants on a 3-unit bridge, which is 3 implants and 3 single-unit crowns?
Yeah, great question. It really is. I think probably, Howard, what it comes down to is anterior versus posterior, in my opinion. So if it's posterior, I would prefer individual implants every time, right?
Every time, yeah.
Every time, yeah. Because so if you're going to go 19, 20, 21, versus a 19, by 21 bridge, I mean, who wants to floss around a bridge, right? Who wants to water pick around that? And you're right. Over time, if you lose one or those implants, right, you got to section it and clean it up. And almost every time you now have a massive bony defect around that area, right? So now you're, you might have got some time out of it, but it sometimes that's driven by cost. Sometimes it's just driven by the restorative dentist. One of the hard things as an oral surgeon is you're trying to not second guess too many treatment plans, right? You're trying to educate your patient, give them options, but not say, oh, hey, Dr. So-and-so sent you over, and I'd rather do 3 implants instead of this 2-unit bridge on you, because then it may, 3-unit bridge. Sometimes it may look like you're just fishing for more procedures versus what you actually might want in your own mouth. So I think when it comes to having individual implants in the anterior, it's hard, right? It's hard to make like 7, 8, 9, 10 look great if they got a narrow palate. They have a gummy smile, and so sometimes that it is better to do an FPD up there and just have them clean it really well. And the other thing up front in that anterior cosmetic zone is that papilla, right? You lose the papilla a lot, right? And so on a FPD, for example, you can make that generally look a little better than individual if they're really tight, narrow, tight long contacts on the anterior teeth don't look that great.
So now, even though I love you to death, I'm going to get you in trouble because I'm going to ask you a question where no matter how you answer, you're going to piss off half the dentists on dental.
No.
The biggest one of the wars. There are dentists out there that say no, you have to have a surgical guide on every implant. If you want to get an A+, it's got to be a surgical guide. And the other half are like, get out of town. I can, whatever. So do you have to have a surgical guide on every implant, or can you lay one with your eye-hand coordination?
Yeah, well, I mean, look, I probably will upset some. I think you don't need a guide on every implant. Now, but you need a guide. I believe you do not need a guide on every implant. I believe you do need a guide often, but you don't need it on every implant. So what it really dictates it is the bony contour, the soft tissue architecture of the area, and is it in the cosmetic zone or aesthetic zone, or is it posterior mandible? So is it what key anatomy is it around? Is it around the inferior alveolar nerve? Is it around the sinus? And so I think implant dentistry really is tricky, and one of the main things that makes it tricky is because you can sit there and say, to some of your dental students or some of your more techie kind of driven students, the software is fun to play with, right? Get a CBCT, marry it with, whatever software you want, pick whatever brand implant in the drop down menu, click the length, and you're like, man, this is awesome. And then, get it milled out, all this kind of thing. So the technology is there, right? But you forget that you might be working for MetLife Insurance, and they might be reimbursing you, I don't know, $1,250 for the implant, right? And so, like, how much can you build in? Can you put graft, PRP, surgical guide? What are you building into that? You're going to digital workflow it, scan it for the referring doctor. So this becomes, in my opinion, where the rubber meets the road. And as a specialist, my thoughts are, I had several doctors when I peeled off a decade ago to do my own thing. They said, like, don't sign up with any insurance companies. Don't do it. Just you got a good name, you can make it. Why do this? And I struggled with it because I thought, I think it will limit access. And as much as I'm not a big fan of these big insurance companies and what they're doing to our profession and how they're driving so much of it, I feel like as a specialist, in my opinion, this might change, but at my current opinion, at my age, I still think it's necessary to be on some of the major plans. And the major plans is, even if you do a high volume with them, right? I had Delta Dental come, I had, it was maybe 18 months ago, I got a call, and my front office is like, hey, somebody from Delta Dental says that the VP of Arizona or something like that wants to come meet with you. I'm like, oh, and my first thought is, what happened? What went wrong, I agreed to the face to face, and I think the VP came out. Somebody in their kind of customer satisfaction kind of thing came out and said, "Hey, what can we do to make things better for you and other providers?"
Good for them.
It was actually cool, a cool visit. And I said, at first I'm like, am I getting punked right now? Like, where's the camera? Like, is this for real? You guys, you're just coming out, and all you want to do is say, hey, you're a high provider for us, and you want some feedback. I said, look, I'm in a group text with some guys I golf with and hang with. If I were to say, hey, I'm here with Delta, what would happen? And I said, look, I'm going to be honest with you. You're going to get a lot of people sending you some bad vibes back on this text. I mean, I work with you because it's necessary. Do I think you're beating us up? Yes. Do I think you got a massive reputation problem amongst dentists? Yes. Can you clean it up? The only way to do it is to reimburse better, right? And so, they took it they took it how they did, and I think the next year they gave Arizona a little bump, not much at all.
Well, I think it's just the pendulum swings. I mean, when I came out here, it was gosh darn, it was Ed Judd, and he would come out to my office. We'd go to lunch. When he didn't like something, he'd call me on the phone, and I'd say, well, let's have lunch, and then I'll come by the office and I'll show you what I mean. And the board of directors was all oral surgeons, endodontists, periodontists that could have worked on me or anyone in my family. And then they decided, well, the board needs to be represented by the patient. So they take out all the providers and lined up with a bunch of Karens and just crazy. And it's like, and then it got this real toxic thing. And I think it'll have to come back. I mean, the relationship, we're both treating a patient, and it doesn't have any intelligence on their half to have a whole board of directors of, again, who guess? Nobody's a dentist. Name me an executive director of a Delta Dental deal that's a dentist. What percent of their board is dentists? I mean, why don't they just fill them all with astrologists? And we'll just zodiac symbols.
Right.
I mean, can we focus on dentistry?
Yeah, it's hard. I mean, I get it. They're running a business too, but they're running it at the peril of the patients and their providers, and with the student-led debt rate coming out by a lot of your listeners, they're going to come out and they're going to say, look, how can I pay my my rent, my car, my student loan? This is all real life stuff that are about to hit them. And then they're going to say, look, what procedures can I do that are going to provide for my family, right? So it's a balance, and wherever you're at, wherever you practice at, I think all you have is your reputation, right? And so you have to do good, clean work. And there's no way around it, right? You can't be dishonest in any aspect of it. All you have is your reputation. So I believe you can be a successful dentist of any kind by doing good, clean work, utilizing a team of good specialists, and picking and choosing which ones you want to do, right? For example, I have a brother-in-law that's also practices in town. I probably get maybe 20% of his implants, and he places 80% of them. Does a great job. It's a good relationship.
And your family tree's got some serious good genetics in it. I mean, was there one stupid average? This is the difference between his family tree and an Irish family tree. Mine's what percent were in prison, and his is what percent were all surgeons and doctors. Be honest. I know this is a tough question. You don't want to say that. You're just a nice guy, but tell the dentist what makes a dentist a great referral for you that you like it, and what are things that dentists do that you sit there and you just like, come on, man, really? And because sometimes they sit there and they're thinking, well, should I do this or that, or what is he gonna think? Yeah. What do we do that's good, and what do we do that's like that you're just, come on?
Well, a couple things. Well, first of all, think about, try to just wear the hat of the specialist for a moment, right? And so, what it's like if you have your day, it's scheduled a certain way, and then if you get a whole bunch of things thrown at you as a general dentist, you get a little cranky maybe as your day goes on if there's too many changes in your schedule. And you want to be predictable. You want to do your best, run on time. You want to serve the community. That's what I want to do too. So sometimes I think general dentists just assume that they can make a call and the patient will get seen immediately, that the specialist is happy to keep his team around for their 45 hours that week or 50 hours for 5 to 10 hours of overhead. And so often when I stay around and I help, which I do and always have, and that's probably helped build my referring repertoire with a lot of dentists. But often it's just to keep the relationship. If you send me 14 over to extract a bone graft, and we've already put in a lot of hours that week, I got to keep a lot of staff around. We may not make anything on that case. I mean, it just helps your patient because I just paid a bunch of people, to stick around and help. So I think to understanding from a general dentist perspective, hey, if I'm calling my oral surgeon, you're saying, hey, so-and-so's in pain, let's try to get them in as soon as you can, and then letting the front office teams go to work, trying to find out what time frame was best to get that patient and how to best manage that. So maybe a little bit more understanding on that end. What makes a great specialist dentist relationship also, it's got to be mutual beneficial, right? And so it's hard because general dentists are sending patients, therefore they're transferring trust and they're transferring potential production onto somebody else's schedule. And so as a specialist, you respect that, you understand it, and you want to serve them well. And then the flip side of that is on the general dental side is you want your specialist to build you up, right? So if Howard Friends send me a patient to do an implant on, I'm going to do my best job to make sure that patient knows, hey, you're at the right dental office. That's your man. That he does awesome work. We work well with that office, and so there's that kind of mutual respect between the offices. It's totally okay for general dentists to keep a lot of their work. I'm not here to have. I have no qualms with that, right? But just when it's work that you feel like it's outside your scope, something that's not in your wheelhouse day to day, just send it out, right? I think that's a big relationship tester, if that makes sense. When you see something repeatedly from an office where you're like, man, I'm fishing this implant out of the sinus, and they're saying, hey, just bill me, right? That's a hard thing to do, right? I had one not too long ago. Hey, I was pushing too hard. This implant popped up in the sinus in 14. I can't get it out. Can you see this patient get out? And they just billed my office. Right. To my knowledge, somebody correct me if I'm wrong, I don't think my office has ever billed a dentist. I have never billed a dentist. Right. Does that make sense? I've never said, hey, here's the cost to do a, open sinus lift, retrieve this, try to get primary closure and rotate a flap over so you don't have a chronic oral enteral communication. Like, that's just not really, that doesn't build any relationship trust. If I'm building your office, that puts a rub there. And so I think what you're trying to do is say, hey, this is what I can predictably do, and this is what I don't do. And that's no different for endo or for perio. For example, I don't do a lot of gingival grafting, right? So if you come in and you say, look, I got this big defect on 24, 25, yes, I could graft it for you. But I mean, I know a number of really talented periodontists. I'm going to pass it off to somebody that's doing that day to day, right? So I think what you do day to day is what you should become proficient, find a way to perfect it, find a way to find joy in doing it, find a way to make a profit at it. There's nothing wrong with making a profit at it, right? In a good, honest, old-fashioned way. But relationships matter in this world. And if you talk to a bunch of specialists out there, I think that's one thing that they won't say very much on the record publicly, but they may say individually, man, I just keep getting burned by this office, and this office. I don't know what I should do. I just got to keep smiling, put a grin on my face and say welcome in. But I don't mind. I feel like it's a duty in a way, and I'm respected for it, if that makes sense. I like people turning to me saying, hey, Paul, can you help me with this complication? And ones that are sincere about it, call my cell phone, send me a thank you note. They don't need to send me anything. You don't need to give me a gift card. You just send me fist bump on a text, thumbs up, thank you, and then send me a couple of cases of wisdom teeth, right? That's really that relationship goes a long way. People have complications. I have complications, right? So it's not a big deal as a dentist to have complications, and as a new dentist, absolutely you're going to have complications, and it's going to come from I prepped tooth number 2, and they're sensitive, and I might have had a pulp exposure to, I was crown prepping 31, and then my drill got the tongue. Whatever the complications happen, it's part of dentistry. It is right, Howard. That's for sure part of dentistry is complications. Knowing how to manage and having a good team to hand off complications to and keep patients happy. I will say this: I get calls from time to time, probably once a month, and it's somebody worried that they're going to be in trouble with the board on something. Hey, Paul, I got a patient. They're numb. They're struggling. I didn't maybe give them enough informed consent. They have lingual paresthesia. What should I do? I will tell you this: if you have trust with your patients, even if you're having a complication, you communicate openly and honest with them, and you involve a specialist. Almost every patient I've been involved with over these years is understanding. They'll work through a problem with you, right? I don't know why people are afraid to refund patients. I mean, maybe there's a consultant out there that would say this that this goes away or admits guilt. But look, if you had an implant that failed and you got a patient that's upset and now you're sending them off to a specialist to help clean it up, refund the patient. I just think that's good practice. Manage it, in my opinion.
What percent of sales does Walmart refund? Let's see. What the
Probably
answer
a lot.
Returns generally range from 14 to 17% of sales. Yeah. And your tight butt's going to the board because you can't refund 1% of sales. I mean, it's a denture. She hates it. You did it. She just wants her money back. You fight with her. Now you're taking the whole day off, losing the stomach lining, going to the board for a refund of a failed implant case. Walmart, 14% of sales. Could you imagine? Could you even survive if you had to refund 14 to 17% of all your implant cases? But speaking of implant cases, I want to ask another tricky question.
Yeah.
So we've. I think Clear Choice was the ultimate DSO. Yeah. I mean, I noticed in the Valley that I remember when Clear Choice came out, first all the oral surgeon paradigms, like, who are these guys? And they're treading, but they were doing so much television advertising. They were raising the sea for everyone. All my patients, I lived through it right here in Ahwatukee. Mm-hmm. People coming in and say, have you seen those infomercials about Clear? And everybody started asking about implants and implants in a day. And they were building the world became woke to dental implants on these Clear Choice. I mean, they did millions of dollars advertising. Yeah. But gosh darn, they go in there, and first of all, is that really a good idea, implants in a day? But I see these cases, and it's like, they have, it's all fixed, and they come in and they have an entire ham sandwich underneath those implant cases. I mean, you do the cleaning with a 3-way syringe. You're just blowing out pancakes and tuna. And I'm thinking, gosh, if they just would have snapped that off and could put it under the sink and brush it and put it back on.
Made an overdenture.
And furthermore, the people, think about your family tree. Think of all the doctors in there. How many in your family tree had to have full mount implant replacement because for whatever reason they just happen to lose all their teeth and need implants? I mean, the people that lose all their teeth and need implants, they're never yoga instructors. They're never vegans. They never, they don't do 5Ks and 10Ks. So it's like, okay, the people who, and I'll just say it out loud. I think the people most likely to have done meth in Apache Junction, lost all their teeth. Now they have fixed implants and no home care history. Yeah. I mean,
no follow up.
I mean, do you really think that maybe those should be removable implants?
Well, when I try to plan them nowadays, I do try to make them either like detachable, like a fixed detachable, or an overdenture more often, especially in the maxilla. Stuff gets stuck in there all the time, more so than the mandible. When Clear Choice came to town, I think it was maybe about 2008 or so. I'd been in my practice a couple years with my partners. They took us out to dinner. They say, hey, we're coming to town. We need some surgeons, right? So they were looking way back then. We initially had that same thing. We were a little fearful because we were doing a lot of. I think we were the first kind of big group practice, at least in the state, doing a lot of full arch hybrids. It was a big part of my training. Biomet 3i at the time, I think they're now called ZMB. His doctor named Carl Drago, a prosthodontist, was one of their beta test sites, and he took a liking to me, and so I did a lot of those cases in residency. So I came out, and there was a need. The East Valley's got a fair amount of retirees, right? And so if you're coming from Iowa and you're general dentist, you drive 75 miles to get to, and they're not offering any sexy dentistry, then it was certainly a train, a wagon to hop on, which a lot of guys did, this hybrid dentistry. It's not without its complications, right? And so a lot of young doctors think that that's their panacea to make a lot of money, right? I disagree strongly with that, right? I mean, hybrids have a lot of complications.
Explain to Delson what you keep saying hybrids. Yeah. What do you mean hybrids?
Well, so it'd be like all on 4, all on X, right? Whether it's 5, 6, 4, whatever implants you want. It's a continuous one. Zirconia is the most common.
But why do you call it a hybrid?
Well, because you start with the denture on your temporary, so your general dentist provides you a denture, right? And then you place the implants, and then you take the denture and you attach it. There's a cut down process through the lab, and nowadays the digital dentistry's even flowed that differently. It used to be just an acrylic denture that then was modified by the lab on site at the surgeon's office, and you walked out with teeth in a day, and you might have 10 to 12 teeth, or depending on what your AP spread, anterior posterior spread of your implants were on either the maxilla or the mandible. So hybrids, they have its purpose for sure. I still do a fair amount of if it's done properly and with a good lab and a patient that's had kind of a come into Jesus moment without a brush and how to take care of things, then maybe they can get those implants to stay clean. But I have patients now that I think the first hybrid I did locally was 19 years ago. I've had a couple find me a dozen years later. They've never once gone back to their general dentist office for the screws to be changed, for anything to come off and be cleaned. And so if there's not great patient education on the general dental side, or there's just natural attrition, right? They're bouncing from one dentist to the other because they move around town, and they're like, hey, I don't have any natural teeth. Why would I need to see anybody to have any cleaned, right? There's a lot of those hybrids in the valley, right? So that's the fixed prosthetic versus the removable, like an overdentures, is a lot more easy to clean. So you're 100% right there, Howard. If you're like, hey, what's easier to clean and maintain? If they pop off the denture, if they clean the abutments, the locator attachments, whatever attachments they have going on there, then that tissue will stay healthy. Great question, though.
Yeah, I mean, I just have never seen. I've just never really seen someone who your past behavior is number one predictor of your future behavior. Mm-hmm. And if your past led up to you losing every single tooth in your head, mm-hmm. I have not seen a 180 come to Jesus brushing, flossing.
There's not too many of those. I can certainly think of some that have, but not too many. You're right. You got to have a complete change of your hygiene and general dentist follow-up, routine hygiene, taking it off, replacing the screws. It's part of it. If you don't have that, then you're going to get some peri-implantitis and fail your implants over time.
Yeah. But it has been a complete honor to have the man, the legend. I mean, really, in Arizona, you're the GOAT. You are.
Well,
you are. Everybody I know. And you're the GOAT, and you're the best, and it's just been an honor to be here. And just thank you so much for talking to the dental students and the townies on Dental Town
it's been
about all things oral surgery, and for what you've done for me personally, my family, my own mouth, and your patients. You're just a hell of a guy. Thank you so much for coming on the show.
I appreciate it, and likewise, I appreciate what you've done for dentistry. I think your impact on dentistry is going to far exceed my impact on dentistry. But I certainly appreciate what you do and continue to do. And to these young dentists, it's worth it. This career is awesome. I mean, be excited. It's good. It continues to be good. Make it your own. Don't just follow along what your classmates are doing. I mean, ownership is big, and education is big, and having mentors is big.
And why was missionary dentistry so big for you? I mean,
Oh, you know what? Well, I think part of that was because I really like to get my kids involved, right? And so I wanted to me personally, if I were going to go to Dominican Republic or Guatemala, I just got back from Guatemala with my daughter, maybe 6 weeks ago. I want them to see what's out there. I want them to see what oral health care is like outside the U.S. It's a big, broad range in the U.S. When you get outside the U.S., I mean, it's just crazy what the lack of access to care is. And so giving back is that's easy, you know.
and it's
just
mind
time.
blowing when I was down in Chiapas and it's night and we're with some dentists and we're cooking some good food and you just felt horrible because they were standing in line in the rain with their babies and they were going to stand in line all night while you're all talking and playing
Yeah.
and sleeping
You-
just to get a chance that their baby can see a doctor. And finally about 9 o'clock your conscience is just killing you. And you're just like, come on, guys, let's go open up the dang clinic. And then they're standing in the rain. But when you see so many patients in America complaining and writing bad Google reviews, and you're all wigged out, and it keeps it real when you see them standing in the rain all night just for the chance to see
Yeah,
a
no,
dentist.
100%.
I just
Give
appreciate
back.
it.
This career is
All
worth
right.
it.
Thanks for coming
Hey,
on the
thanks,
show.
Howard. Appreciate you.